Hello, everybody. It's Dr. T here, back on a Tuesday night, 7:30 Perth time. How are you guys? I feel like I've been away for a really, really, really long time. It's been 3 weeks. It reminds me of a conversation I had with a patient today where we were talking about the importance of expectations and understanding time. And we sort of talked about, how long is that 3 to 4 weeks at the end of a 9-month pregnancy? Just to really put it in perspective. It's one of those conversations. How are you? Are you good? Lovely to see you all online. Have you guys had some holidays? If you have, let me know. Drop it in the chat. I'd love to know where you went. I was one of those people who hadn't updated the passports in time. So had a nice staycation. Staying in Perth. Who's over the cold? So over the cold. Bring on summer. Good to see you guys coming on. Hey. All right, so rapid fire Q&A. Back to our usual Tuesday night, 7:30 rapid fire Q&A. Let's aim for about 10 minutes. I am actually quite shattered. To all of those of you who have given me a massive shout out in my new digs at Pivot Medical Centre, thank you. Shout out to all my friends at Repromed for hosting me for a couple of days. Really appreciated the opportunity to come and check out the amazing things that you are doing in the fertility space and how you're really improving that patient journey for people. I learned some great stuff. And I've got to share, while I'm waiting for you guys to drop some questions, because I've only got one, but I'll jump to that in a sec. But I am totally living the discomfort journey right now. So I've always been a massive believer of growth happens outside the comfort zone, and that the only way you're really going to grow and develop as a person, your skill set, your knowledge, personal growth is when you're feeling really uncomfortable. Well, that's me right now. I am in a state of constant discomfort right now. Yep, I'm expecting massive growth to be occurring, but I'm enjoying it. I'm actually enjoying being uncomfortable and stretching my boundaries, because that's what you want in life, is to just constantly improve and get better and be of better service to everybody. So it's good. Right, Q&A. To those of you who have popped on and are waiting, this is how we run Q&A. Drop a question into the comments section. I can guarantee if you've got a burning question, someone else will want to know the answer to that question. So it's going to be helpful for everybody. Just some guidelines around asking questions. Please try and keep it as generic as possible and short as possible. I really don't want your life story. I don't need your whole medical background. Just a short, sharp question. The answers that I give will also be quite short, sharp and generic as possible so that they apply to a wider group of people. If you've got a really complex case, I'm not going to do any medical diagnosis on here. Please come and see me. I would love to help you. I'd love to delve into your history and your investigations and try and figure out what you might need some help with. But let's just keep those questions short and sharp. So before I gabble on too much more, just waiting for those questions to come through, I did get asked a question by Sammy. I don't know if Sammy's on here, but she asked me the question. Let me paraphrase this. My husband and I have been trying for around about 6 months. He's a bit concerned that we're not moving forward and falling pregnant. Is it too early at 6 months to seek some sort of investigations? And my answer to that is absolutely not. Just going back to basics, the definition of infertility or subfertility, I'll call it subfertility because in the vast majority of cases, we can help you conceive. So it's not that you're infertile. Infertile means you're never going to conceive. But the diagnosis really is 12 months of regular timed intercourse without contraception, but not conceiving. Right? So that's the definition of infertility. We shorten that to 6 months if you have a woman where she's 35 or older, just simply because we know that age and time is of an issue. So if we think about the question that was asked from Sammy, It's been 6 months. We've been trying. If you're over 35, I would say absolutely get yourself along for a fertility checkup. Absolutely. Because we don't necessarily have another 6 months to dilly-dally. To those who might be under 35, and it's a bit of an arbitrary cutoff, but to those who are under 35, is it reasonable to go and get some fertility investigations when you've been trying for 6 months? I think it is. I think it's really reasonable because the fertility journey, even if you're at the beginning of it, can be quite anxiety provoking. And so if you are worrying all the time, are my tubes open? Is my husband's sperm actually normal? I don't even know if I'm ovulating, and are we timing intercourse the right way? If you need answers to those questions to help you through the process, to help you understand the process a bit better, then it's really, really reasonable to seek some basic investigations. There are GPs out there who work in this fertility space who can facilitate those basic fertility checkups. So you can attend a GP and you can get a sperm check done, and you can get an ovulation cycle tested, and you can get a tubal patency test. The one thing I would always say is you've got to be prepared to act on the results that you receive. So I have had some patients have an extremely traumatic experience receiving information about their low ovarian reserve if they've had an AMH tested, for example. Understanding, of course, that AMH as a measure of ovarian reserve is not actually an assessment of fertility. It really just tells you how much time you've got left. So I think it's really important to have in your mind, right, we want the investigations done, but it may actually lead to that doctor saying, oh, you've actually got blocked tubes, you need IVF. So you've got to be prepared to act on the results that you get. Similarly, you may be told at 6 months, can't actually find anything that is wrong. And it might just be our gross test, or it might just be that you need a little bit more time to conceive. So I think it's really reasonable for you to ask the question, can we have some basic fertility investigations, acknowledging that it's a couple thing, you both have to be investigated, and you need to be prepared to act on the results. So hopefully, Sammy, that was a helpful answer. Now, I did see some other questions coming through. Thank you for dropping them in. Life of Brit. How long does it take to see effects results from taking metformin? I guess it depends why you're taking metformin, Life of Brit. If you're taking it to regulate your cycle, perhaps you have a little bit of disordered ovulation, you may see the effects of that over a series of months. So you may be able to look back and go, hey, look, my cycle was 35 days now. It's a 28-day cycle. You may see some effects there. Not everybody does. If you are taking it to improve your sugars, maybe you have some insulin resistance, the effect you'll start to see that almost immediately, because metformin is like an insulin sensitizer. It unlocks the cell to allow the cell to, be sensitive to insulin, to then allow the cells to take up sugar, so there's not so much sugar in the blood. So you will start to see that effect within days on sort of your endocrine milieu. Weight loss, there is sort of between a 2 and 5 kilogram weight loss thought attributable to metformin. Probably we'll see that over weeks to months. Depends what else is going on in your life. So hopefully that answers your question. I use metformin in a couple of different ways. I don't use it as an ovulation induction agent, but I use it as part of ovulation induction. So I wouldn't give it to a patient with the intention of inducing ovulation, if that makes sense. So hopefully that helps answer your question. Mum in the making, any thoughts on Zoladex and endometriosis treatment? Yeah, I got lots of thoughts. Zoladex. So what everyone else is going, what's Zoladex? So Zoladex is a GnRH analog. What's that? So there is a hormone in your brain produced by the hypothalamus which turns on the pituitary gland, bang, to produce FSH and LH, which then go and turn on the ovaries to make you ovulate. So what Zoladex actually does is blocks the brain signaling to the pituitary gland, and so the pituitary kind of goes back to sleep with your FSH and LH production, which then in turns put the ovary back to sleep. What it does do is induce a temporary menopause. So there are some side effects, menopause-like side effects, as a result of having really low estrogen because the ovaries have kind of gone back to sleep. From an endometriosis point of view, what that means is that you don't have any estrogen feeding those little deposits of endometriosis. So essentially you suppress the disease. Why are we talking about this on Rapid Fire Q&A? Well, we do have some evidence to show that if you suppress endometriosis, you're going to suppress that inflamed environment within the pelvis and hopefully then improve, I guess, the endometrial receptivity to allow an embryo to stick in the uterus. And so we often will use it in IVF treatment to help improve endometrial receptivity of a woman who has endometriosis. Because we know that endometriosis, we know it's a horrible disease, but we know it can affect multiple aspects of fertility, tubal blockage, quality of embryos, but also the endometrial receptivity. And so I think it has great value, either post-operatively before transferring an embryo or in its own space to medically suppress severe endo where surgery itself doesn't necessarily improve outcomes. All right, hopefully that was helpful. I think I banged on a bit too much there. Oh, here's another question. Good one. Why do some women with PCOS not respond to letrozole? So, why do some women not respond? So what letrozole is an aromatase inhibitor. So it inhibits the conversion of androgens to estrogen. So aromatase is the enzyme that does that. And so by inhibiting the conversion of androgens to estrogen, it drops the estrogen drive back to the brain. And so the brain goes, oh, let's ovulate. So if you are having an enormous amount of estrogen being produced by different tissues, such as body fat, because that produces low potency estrogens, then you're going to find difficulty with that. So that's probably the reason why some women don't respond to aromatase inhibitors. So you've really got to look in PCOS, you've really got to look at the lifestyle things. You've really got to reduce that insulin drive to the ovaries, which is going to increase the hyperinsulinemia, which is going to increase the androgens. So it's about perhaps considering a lot of other things in association with just using letrozole. And that's women with PCOS you're talking about. I'm not going to go into the other reasons why it might not work, might not be the right treatment. PCOS might not be the diagnosis, but anyway, not going there. What type of testing is generally done for donor sperm to be sure it's good quality prior to use? You can actually extend that question is what test do we do to test anyone's sperm to assume it's good quality? There is no really good definition of quality assessment. When we do an assessment of semen, or sperm rather, we're testing how many have they got, concentration or count, how well they move forward, which is motility, and what they look like under the microscope, morphology. And we compare it to some World Health Organization data. As far as looking deeper into sperm quality, some labs do DNA fragmentation testing, so looking at the amount of oxidative stress on sperm, although there's not fantastic data for the tests themselves. That's not done on donor sperm. So mostly it's just looking at those gross parameters. They do infection screen on the donors to look at communicable diseases, but again, that doesn't really assess the quality. So you raise a really great point. Is the sperm coming from a donor, which is an absolute gift? And let me tell you, sperm donors are, they're not walking in off the street. So sometimes you get what you get, right? But who's to say that a sperm donor might not be morbidly obese, might have medical conditions on medications. And so these things can affect sperm quality. So Georgia, you make a really great comment about how do we ensure it's good quality. Well, we really only look at those gross parameters and infection screen, to keep you safe and the health of your future child safe. But as far as quality assessment goes, there would be very, very little. And some would argue that, well, given that there are so few donors out there prepared to give their gift, then you kind of get what you get. So, but great question. That's got me really thinking. I had to think hard about the answer to that one. All right, any other questions? No worries, Life of Brit. My pleasure. Oh, there's some people in here that I know. Good to see you guys. Mum in the make. Oh, a wealth of knowledge. I don't know. Sometimes I am, and sometimes I just have to say I don't know, and I'll go and look it up. But it's good. I'll go and do reading off the back of this. This is great. Any other questions, guys? I think I'm well and truly done my 10 minutes. I like to chat, don't I? Well, sometimes I do. Sometimes I think I'm a little bit of an extroverted introvert. Anyone like that? They just love their time on the couch in their tracksuit. Any more questions? I think I might have answered all the ones that are posted, and I know I've done more than 10 minutes. So I want to thank you guys so much for jumping on tonight. I didn't see any other questions. I don't think I missed anything. I am going to be back next Tuesday night. I'm heading off to the ANZREI conference in Sydney this weekend. That's the meeting of all of the subspecialists in reproductive endocrinology and infertility. I think there's about 80 of us getting together to party, to learn from some amazing people. So hopefully I've got more cool stuff to bring back to you. Have a beautiful rest of your week. I wish you all the best. Please, if there was any information that you found really valuable and think would be valuable to others, tag them in, share the love, and I'll see you next week. Bye.